everyone, and welcome today to Raj's webinar on data incompleteness in electronic healthcare records. Before we start, I'd like to take a moment to acknowledge the traditional owners of the lands where we are today. So QUT acknowledges the Turrbal and Yagara as the First Nations owners of the lands where QUT now stands. We pay respect to their elders, laws, customs, and creation spirits. We recognise that these lands have always been places of teaching, research, and learning. QUT acknowledges the important role that Aboriginal and Torres Strait Islander people play within our QUT community. Now, thank you all for being here, and I would like to firstly introduce our speaker, Dr. Varadraj Gurupur. So Dr. Varadraj Gurupur is currently working as a tenured professor with the School of Health Management and Informatics, and has a joint appointment with the Department of Computer Science and Department of Electrical and Computer Engineering with the University of Central Florida. He is also the founding member of the Center for Decision Support Systems and Informatics at UCF. Dr. Gurupur has received his doctoral degree in computer engineering from the University of Alabama at Birmingham in 2010. He has authored or co-authored more than 100 peer-reviewed publications and is a recipient of several honors and awards such as the AHEMA Triumph Award for Research, AHEMA Triumph Award for Innovation, and Joseph M. Biedenbach Outstanding Engineering Education Award from IEEE Region 3. He is also currently serving as the Area 3 Chair for IEEE Region 3, and he'll be speaking today about data incompleteness and why it's a problem in electronic health record systems. Thank you, Raj.
Thank you, Fiona, Ashley, Kalyan, Sandeep, everybody here for getting this thing ready for presentation. And also a big thank you for folks who are here in the audience. I might forget to thank you at the end of the presentation, so I want to thank you in advance. So my topic today, and this is a topic that I've been researching on for the last 15 years, more than 15 years actually, is on incompleteness of electronic health records. Because this is a problem that I've been working on for many, many years. As Maitreyi rightly introduced me, I'm a tenured professor with the School of Global Health Management and Informatics with the University of Central Florida, located in Orlando, Florida. Maitreyi has already done a great job introducing me to the audience, so I don't have to do much. I have a PhD in computer engineering with a master's and bachelor's in computer science. I have more than 100 peer-reviewed publications. I got international national recognitions at US, and I have had the privilege of mentoring so many students in research. Also, I'm currently a chair of the IEEE ICAD work group on global data quality standards for electronic health records. So that's my introduction. So I have a strange mix. I come from a engineering, computer science background, and I have a work experience working in healthcare in the area of electronic health record systems. So what is data incompleteness with respect to electronic health records? So this is one of the big questions that is always asked to me about data incompleteness. Let me give you a little background. Back in 2007, I was hired as a data manager for the Alzheimer's Disease Research Center with the University of Alabama at Birmingham. And my job was to pull out records that were incomplete and find the part that was incomplete and fill up the record and make it complete. So that was my job. That was my bread and butter. So, I just had to do it because I got paid for doing it. But when I became a faculty, I thought, this is a problem that's worth exploring. But before we start exploring the problem, you got to define the problem. And the definition for the problem came many, many years after I started exploring and started researching on the problem. More recently, just a couple of years ago, we formed the ICAD work group for global data quality standards for electronic health records with the IEEE Standards Association. So our group defined incompleteness of electronic health records as a situation where a data element is missing from an electronic health record. Very simple. For example, there could be a heart patient, the blood pressure, the most recent blood pressure data was missing. It could be that there's a patient walking into a clinic the first name is missing, or a last name or surname, as we call it here in Australia, is missing. It could be that the information on the payer in the US, more relevant in the US than in Australia and UK, I believe, is missing. Or it could be some vital, critical part, clinical information or clinical data that is missing from an electronic health record. So this is what incompleteness of electronic health records basically means. Because, sometimes in the past, I've had this problem where I give a long presentation on incompleteness of electronic health records, and then someone in the audience asked me at the end, hey, what do you mean by incompleteness? I just didn't get it. So I just decided I'm going to start with the definition of incompleteness with respect to electronic health records and explain you what this incompleteness is about in terms of its definition. All right. So very simple. So then, going back to 2019, we got a grant, $50,000 grant from National Science Foundation in the United States to figure out if misdiagnosis, analyze data incompleteness or data completeness and inconsistency is a problem leading to misdiagnosis of or reimbursement problem with patients. And we interviewed 252 participants across the electronic health record ecosystem, or should I say the healthcare ecosystem. And we got a lot of interesting facts. We interviewed CMIOs of big electronic health record system providers. We interviewed people, folks from the government. We interviewed, regular patients, regular doctors. Some folks I would like to define as data plumbers. These are people who fix data problems with the electronic health record systems. So we were able to interview folks across the spectrum, and what we found was like really, really amazing and eye-opening, I must say. And I'm going to reveal some of those eye-opening facts today at this webinar, and let you ask me more questions on it if you have to. Then what happened was, we published a lot of conference papers and journal articles based on those research findings, and we decided to jump in again, do a second deep dive into this problem of incompleteness of electronic health records, because between 2019 and 2026, we got AI walking into the picture. We had a lot of amazing computer science or computational related innovations that are being used by a common user these days, which wasn't the case back in 2019. So we decided to do one more deep dive into this problem. This time we interviewed 207 participants, and we got some really amazing results as well. So want to acknowledge the NSF grant this time as well. So broadly, what is this problem creating from a payment point of view, or if you are running a hospital, you're worried about money, you're running the budget for the hospital, you're running, or maybe you are someone who wants the patients to be taken care of properly. What does this mean? Where is the value? Why should we do a deep dive into this problem, right? So that is the first question that we need to ask. So here's the value proposition. If this problem is resolved, let's say our ideal situation, this problem is resolved completely, the revenue for the hospitals might increase 12%. That's good for the CEO of the outpatient clinics. And, hey, if you're looking for money, that's where it is. You need not hire so much staff members in the hospital, because, there are systems that can check for incompleteness and tell you that here is where the incompleteness happens. There could be a reduction in provider negligence, and I can tell you a story on this one. I had a fracture in my right leg, and I was about to get into the surgery room, and they were about to mark my left leg. I said, no, that's not where the fracture is. It's on the other leg. So thankfully, I saw, that mistake happening, and the surgery went really well. So I'm sitting right next to an orthopedic surgeon right here. So, this is the type of thing that can happen when data is missing or incomplete. You can't send a patient to a surgery room unless the surgeon has all the data, right? That's a clinical problem and can have clinical relevance, also can have relevance in terms of reimbursement from the payer. So this is like a demon that has 100 heads or maybe 1,000 heads. You kick out one head, the other head shows up, right? So this is overall, these are the problems that can happen because of incompleteness, and these are the good things that can happen if this problem is resolved. So a bigger picture of that from a value point of view. Now, more recently, we are now living in the age of AI, and we decided to take a deeper dive, right, into this incompleteness problem. Boy, take a look at this now. This is how complicated this problem is. You got an impact. Now, if I have to focus on the impact, because if you're a CEO, CIO, CMIO, you're looking at the impact. You are looking at the big picture. Why do I need to dwell into this problem of data incompleteness? Right? You got 83% report missing or delayed data. You got, lack of real-time checking. You have more people who are more reactive than proactive. You got the available costs or the healthcare costs just climbing the ladder, because back in the days, people used charts, paper charts. Now those paper charts are gone. Now all you have is this electronic health record, which is all electronic. And technology has its own challenges. Like, for example, we before setting up this presentation, we were checking if everything was going right. Imagine if there's a patient trying to get into a surgical room. Don't you think you have to look at all the data before you send the surgeon to the surgical operating room? So that's the kind of thing you got to deal with. So it's better to be proactive than to be reactive. And kind of, if you are the CEO of a hospital, CIO of a hospital, this is something you got to get a look into. I was thinking that there are places in this world like UK has NHS. They have a perfect situation. They don't have to deal with all the complications that people deal with in places like Finland or US or other places in the world. And lo and behold, I got a message on LinkedIn after I gave a presentation and said, Dr. Gurupur, we have this problem in UK as well. I said, oh my God, I thought you guys were perfect. Yeah, so, this is a problem that needs to be dealt with. And thankfully, we have AI and we have other paraphernalia that we can get access to that can be used to solve this problem. So let's take a look at this problem from a very generalistic point of view. You got a patient, approaching the registration desk at a hospital or a clinic, introducing that, hey, I got a clinic appointment at 10 o'clock, or I just showed up, I have this problem. And then the registration desk personnel checks the patient for some information like identifying information like name, surname, maybe your national identification number. Like in the US, we use social security number, right? Stuff like that. And then, once the patient is checked in, then the patient is sent to the nursing staff who checks the patient for vitals like blood pressure, height, weight, and BMI, all that stuff. And then finally, the patient is sent to the physician room where the patient is seen by the physician. And, then the physician might prescribe for some lab tests, and the diagnostics information goes into the electronic health records. Also the prescription information goes into the electronic health records, and finally goes to medical billing, whatever form of whoever the payer is. Many times it will be the private insurance or the government, depending on where you are, in which part of the world, and how things work over there. And then, that's how, things work, right? So we identified there could be potentially 4 gaps. First, where the patient is identified at the registration desk. If there's a communication problem there could be the first line of incompleteness coming in, like a surname missing or a first name missing, all that. And then if the nurse is not recording all the vitals, maybe the nurse forgot to check the blood pressure, or the physician forgot to do something somewhere down the road, something was missing. So these are the critical gaps, and I would love to have folks in Australia take a look at this diagram and maybe improvise on it and tell me that in Australia this is how it works, and I'm open to any suggestions on that one. So the gap number 1, generally human errors, right? And I'll give you a funny story. I had a family member. I had to take him to a hospital late in the night. And then he was trying to spell his name. And he said J-A-Y. And when he said Y, maybe the way he pronounced Y, the nurse or the lady at the registration desk couldn't figure it out. And she said, I don't know why. But actually, he was spelling out his name, J-A-Y-A, and so on. So, there could be a communication gap, right, at the front desk. It could be a lingual gap at times. Stuff like that can happen. So this is gap number 1, I call it. And gap number 2, you got the nursing staff gathering the information, the vitals and all that. And if there's anything missing over there, that could be gap number 2. Gap number 3 is maybe the doctor forgot to write something. Maybe the patient has diabetes and the doctor forgot to write that the patient is diabetic. Or maybe the patient has depression and the doctor forgot to mention the level of depression. For example, in the US, we use something called HCC, Hierarchical Category Code, which identifies the level of depression. If you have depression, just the fact that you have depression is not good enough. You got to write about the level of depression. If it's low, then the reimbursement is lower. Medium, reimbursement could be higher. Higher the level of depression, reimbursement could be higher. So, from a payment point of view, you want to record a higher level of depression. Just joking about that. So that's how it works. Gap 4 is the payer. If the payer could be the government, the payer could be a private insurance, or could be someone, or maybe self-paid, right? There, the payer is not getting enough information to make the reimbursement. And this is the case in the US most of the time, where there are companies out there just feeding on this problem of the hospital is not getting the payment. So they go figure out what is missing. They complete the package and send it to the payer. And once the payer pays the amount to the healthcare provider, this company expects 10% of that money. So that's how these companies exist. So that's gap number 4, which is actually a breadwinner for a lot of companies out there in the US, and maybe in other parts of the world as well, who knows. So we started, as an academician, I started thinking about how to approach this problem. So the idea that I came up with was develop a concept map on ontology, which has all the necessary parts of a patient record. For example, personal information is one category, one branch in that ontology. Insurance information is another branch. Medical background is another branch. So a previous medical history of the patient, could dwell deeper into that. Could be family history. You could dwell deeper into that. Personal information, address, date of birth, phone number, email, all that could be, you could dwell deeper into that part as well. So what you do is you develop an ontology and tell yourself, these are the elements that I want. These are the optional elements, and these are the necessary elements, right? For example, it could be that if you already have a phone number, email could be optional. or the other way around. This is, you develop an ontology of what needs to be captured, right? And then, we come up with something called the record strength score. If you are a CMIO, CIO, a CEO of a hospital, healthcare facility, you want to measure, quantify incompleteness of health records. So what do? We have something called record strength score, RSS. So here, your X1 is the existence or non-existence of that part of the electronic health record. For example, if I have to take X1 as the first name of the patient, is X1 missing or is X1 existing? X1 is existing, so X1 is true. That means X1 is 1. What is IW1 is the weight of that particular part of the electronic health record, or the component of the electronic health record. So what is the weightage? Is it 100% necessary or is it not necessary? For example, in the US, you may not have a first name, and that's fine. Your family name becomes your first name as well as your family name. So I had a friend, her family name was the same as the first name because her first name was missing. So, certainly, the first name is not that life and death situation important, okay? Always good to have a first name in the record, but not very, very, very critical. Let me put it that way. But if you have a heart patient walking in and the blood pressure of that heart patient is not recorded, if that is X2, and if X2 is 0, then IW2 is also should be very high because the weightage is also high. You have an Alzheimer's patient walking in, and if the level of memory disorder for that particular patient is not recorded, during the last visit is not recorded, that weightage would also be extremely high. So IW is the weightage, and X 1 through N is the presence or non-existence of that particular component. So summation of that divided by the summation of all the weights times 100 would give you the RSS score, the record strength score. Okay, very simple math. I figured out that simple things are more powerful than writing a very complicated equation. So now you go back to the map, right? The concept map. Now you say the company IW100. So here, I got all IW100s, which means that everything is important. They're all equally important. Okay, which is not the case, but this is like an easier situation to deal with if we have to. Then you look at it. Oh, record strength score. What is missing? What is not missing? If something is missing, X is equal to 0. Something is not missing, X is equal to 1. Then you calculate the record strength score. Now we come up with a higher level of score called the PDS, patient database score, where we do the summation of all the record strength score for that particular patient divided by the number of records that exist for that particular patient. Okay, it could be that a particular patient has communication issues, which is why this PDS percentage is low. It could be that patient is well informed, good at communication, PDS could be high. So per patient, take a look at the completeness score for that patient. So we got a patent on this one way back in 2020, so that this is one of the things that we came up with. It's used by some academicians across the globe now. We did a incompleteness analysis based on this for the healthcare utilization project data for 2014 for the state of Florida. And you can see the categorization of what type of patient had higher level of completeness and what type of patient had lower level of incompleteness. And this is published information that is publicly available. So then we did a Kolmogorov-Smirnov test to figure out the prediction, the distance between prediction and the actual data of incompleteness. So as you know, AI systems are dependent on predictability. So we did that. Here's a very interesting graph. You look at this. These are your variables or components in a electronic health records. This will tell you if this record is missing, what is the correlation that the other record is also missing? You know, and what is the correlation that it is not missing at all? So, you know, the positive and negative correlation. If this is not missing, is this is missing? If this is missing, this is also missing. So a dark blue one is a positive correlation. This is missing, that means the other thing is also missing. I'll give you one great example. First name is missing, very good chance that the last name is also missing because the name was never recorded, right? So this is positive correlation, this is negative correlation, and you can see the heat map between positive correlation and negative correlation. A CMIO or the CEO or the high-level administrator at the clinic can generate a map of this sort for that particular facility and see where the data can go missing. And I was trying to explain this concept to a journalist a few years ago, and I told the journalist, let me give you an example where you think there's plumbing issues at your home, there's water leaking, but you can't tell exactly where the water is leaking. So, you know, our system will tell you where the water is leaking, but we don't know how to fix the problem. We cannot fix the problem for you. For that, you have to call the plumber to change the pipe or fix the pipe or whatever. But we can tell you where the water is leaking so that will help you a little bit. Maybe the water is leaking out of this bathroom, stop using that bathroom if you have multiple bathrooms at your home. So that kind of stuff, right? We don't have the solution to the problem, but what we do have is trying to help you figure out where the problem is happening, all right? So this is one heat map. Heat map is a great way to categorize. Now, since I'm an academician, I got a PhD in computer engineering, you know, I like math. Maybe you don't, or maybe you do, I don't know. But we try to figure out using information entropy to find out the certainty and uncertainty of incompleteness. So here, this dark red circle indicates a higher level of uncertainty, right? And this is, you know, a lower level of uncertainty. Lower level of uncertainty means, you know, first name missing, that means, you know, the last name is also missing. A high level of uncertainty, you don't know. You know, you're getting into the don't know areas. You know, as you climb branches, you know, it gets more and more shakier, right? So in a tree, I used to climb a tree when I was a kid, and as I climbed higher, it got a little bit more shakier and you know, a little bit more uncertain. So I started climbing down. So that's the kind of situation that we are looking at here in terms of uncertainty and certainty of incompleteness. And for that, the best way to analyze it is using information entropy. So information entropy is used by a lot of predictive systems. These AI engines, they're not going to dish out their secret sauce. So they're not going to tell you what things they use. But as an academician, as a teacher, as an educator, we can tell you the kind of ingredients you could use in a secret sauce if you have to. The other thing to look at is the recurrent data. For example, if a patient walks into a memory disorders clinic, right? The previous time the patient walked in, the level of memory disorder was never recorded. But then the visit before that, the level of memory disorder was recorded. So there, you know, what happens is, especially I'm giving this case of memory disorder because memory disorders, generally speaking, they increase, they get worse, or they stay the same. The best case situation is you want the memory disorder to stay stagnant and not get worse, right? So that's where your time series data, your recurrent neural network data comes handy. And we came up with the idea to map chronic condition mapping that was missing or not missing And we got a patent on that one as well. So we wrote a paper on this one. Happy to share the paper with you guys. So now I was talking to you about ontologies, right? I showed you this concept map where we started back in 2015 to figure out this problem of incompleteness, or to figure out the analysis of this problem of incompleteness. Now we are going one step higher. In 2021, we decided we are going to use LSTM and then associate that with an ontology, which means we are basically improvising an LSTM, and we are, adding a kind of ontology into the LSTM, which makes it way more complicated computationally. It would consume more power. It would consume more computational time. It increases the computational complexity. All that, yes, I agree from a computational point of view. But we wanted to see if this can help predict incompleteness, especially for the recurrent neural network situation. For if you're looking at time series data, especially in the case of the Alzheimer's patients, for example. Sometimes in the case of diabetes patients. Now, the good thing about diabetic patients is diabetes is reversible. You can improvise your situation, you can improvise your diet, and you can get a lower level of A1C. That can happen. You can move from diabetic to pre-diabetic. So I have friends who've done that. So, using LSTM and you associating that with an ontology can be of help. So that's something that we looked at. We also looked at the predicting incompleteness during COVID. And again, I did discuss about Kolmogorov-Smirnov test, trying to see the distance between predicted data and actual data is something that we did. And as I said, we looked at chronic conditions, and the student who worked with me in 2015, he ended up becoming a doctor, and he called me up one day and, Dr. Gurupur, now I'm seeing patients, I see a bigger problem, that's chronic condition mapping. And we need to have a proper chronic condition mapping and see if the patients were not recorded for their chronic condition, existing chronic condition during subsequent visits. So this is something that we looked at, and we came up with a formula to quantify missingness of chronic conditions. So that's something that we did, turned out into another patent. And this is so I go around the world, kind of preaching that these are the things we've done. So this is another thing we worked at. So ultimately, this is what we are trying to do, right? This is our ultimate end goal. This is what we are working on. This is what I want to do. Working with researchers, working with people, working with students, working with postdocs, working with interested human beings across the world, is build a system like this where you have attributes in the data incompleteness. Like, for example, I showed you that heat map. So this is, we are looking at the heat map of how the incomplete data components could be related to one another. You could have an incomplete analysis component where incompleteness could be measured as the data is coming in from the reports and the electronic health records. You could have knowledge base and machine learning algorithms that improvise the idea on how data incompleteness must be analyzed or quantified. Maybe we came up with a method of quantifying incompleteness in electronic health records. Maybe that's not a perfect method. Maybe you guys have a better method to quantify incompleteness of electronic health records. Maybe you can explore, you can tell the world that, hey, this is what Dr. Gurupur and his team came up with, and this is what I have come up with, which is better than what he has done. That's fine. We are trying to advance healthcare delivery for humanity across the globe. So I'm inviting you to do that kind of stuff. Other thing is data hierarchy. What applies to some countries may not apply in to other countries or maybe within states within a particular country, for example, may do it differently. Maybe cities within a particular state might do it differently. So the hierarchy or the ontology of the data structure could be different in different places, right? And that's all that is fed by the health informatics expert, the folks that I have here in the audience, some of them. So this is, what we should, as humanity, as human beings, I must say, this is what we should do to deal with this problem so that we can provide better healthcare outcomes to patients. Like in the beginning of the presentation, I gave you this example of my wrong leg being marked before I was about to be taken into the surgery room. Thank God I saw that and I started screaming and the nurse started marking the right leg. Imagine what would have happened if I had not identified that problem. All right, the outcome would have been totally different, totally catastrophic for me as a patient. So these are certain things that need to be looked at for better healthcare outcomes, because ultimately whoever is paying for the healthcare delivery, it could be the government, it could be the individual, it could be an insurance company, they can save a lot of money. And the patients get better healthcare outcome, it's good for the patients. Imagine if the patient is a child, it's good for the child and good for the parents. So it can be more than one individual. So this is a problem that needs to be analyzed, needs to be talked about, needs to have needs to be analyzed scientifically using better math, better computational techniques, better AI algorithms, and all that. And I'm honored to be here in the presence of my good friend, Dr. Sandeep Reddy, who's an AI expert in healthcare, and there are many other folks here in this virtual room. So this is something to be looked at and something that we need to focus on for better healthcare outcomes. So this is approaching my last slide. Thank you, QUT. I want to thank everybody who's made this thing happen. I have a workshop presentation tomorrow, but this is a webinar that we delivered virtually. And one way or the other, although COVID was really a bad thing that should have never happened, one thing we learned out of COVID was to have virtual presentations and virtual classrooms and virtual conversations and virtual meetings. So that was something good that came out of COVID, out of all the bad things that happened, right? So thank you all thank you all, and once again thank you all, and I would open the floor for any questions or comments that you may have. We have our moderator who's going to help us with that.
Yeah.
So.
Yes. Hi again, everyone. So thank you, Raj, first of all, for that excellent presentation on data incompleteness. As Raj said, the floor is now open for questions. If you have any questions, please feel free to put them into the Q&A, which you can find at the bottom of your screen on Zoom. While you guys are doing that, I do have a couple of announcements. So as Raj mentioned, he is doing a workshop at QUT tomorrow at the Gardens Point campus. That is internal only for QUT students and staff. If anybody is interested in that, you should have received an invitation through Center for Data Science. If you're interested, please accept and attend. All of the details are provided in that calendar invite. If you don't currently have a calendar invite, but you are keen to perhaps attend, please let myself, Raj, or somebody at the CDS know so that we can forward you the invitation. I'm also being told that if you'd like to talk in order to ask your question, you're also more than welcome to do that. I think the option would be to use the raise hands button at the bottom of your screen. But while you're all doing that and, preparing your questions, I think I'd like to start off with the first question, if I may, for you, Raj. So you talked about this research as essentially identifying leaks in the plumbing was the analogy that you used. And you talked about you can find out where the leak is, but you can't necessarily fix it. I'm sort of wondering, going back to the other end of this problem, are you able to trace where the leak came from or where the gaps are coming from through some of these aspects that you've worked on?
Sometimes yes, and sometimes no. I'll tell you where it can be yes and where it can be no. If the root cause of this data incompleteness is a problem with another piece of data, the answer is yes. If the root cause of incompleteness is a human or a human process related issue, the answer would be no. Now, for example, there could be a physician who is not very good at, recording patient information. Want to be quick, fast, easy, so that that physician can see more patients every day, for example, or or the physician wants to see a few patients and just run away and do other things. That's we can say our process will identify that this particular physician is not doing a great job capturing data. So that much we can do. But why is the physician not capturing data? Is it because the environment at work? Is it because of personal reasons? That is an area where we can't get into. So the answer is both yes and no. So, if the root cause is a human process related issue, the answer is no. If it is another data, then the answer is yes.
Awesome. Thank you, Raj. I can see a question in the Q&A. So, hi, Dr. Raj. Thank you very much for the presentation. Does your team look into synthetic data approaches applied to data incompleteness?
Thank you. That is an excellent question. Now there are softwares out there, and this is my personal opinion that what I'm about to say. There are softwares out there that if the physician's office forgot to record the blood pressure of the patient, they'll try to predict the blood pressure of the patient. And I think that should not be done. That can be very, very catastrophic. You don't want to give the control to AI to figure out the value that you don't know. So I would highly recommend from a human point of view, as a computer engineer, but also as a person who worked for a hospital who was worried about the patients coming to the hospital. From a human point of view, purely as a human being, I would not want to generate synthetic data when the actual data is missing. Instead, what the better thing to do is figure out why the data is missing. It could be a process issue. It could be hundreds of different issues, right? Let's try to figure out why the data is missing, and let's try to fix the process problem rather than put a band-aid, like throwing in some synthetic data, which can actually not improve healthcare outcome. It can actually worsen the healthcare outcome. So if our end goal is to improve healthcare outcomes, you should never use synthetic data to fill the gap or fill the missing data. Instead, always go back, although it could be cumbersome, it could be politically inconvenient because there could be a doctor who is not doing a job. He could be a very powerful doctor. Nobody wants to talk against that person. So it could be politically inconvenient at times. But from a human point of view, you got to investigate into the root cause of the problem rather than have a computer create some fake patient data and just throw it into the system. So that's my point of view.
Awesome, thank you. We have another question regarding your ontology-informed LSTM. So the question is, thanks to Raj for the insightful presentation. I have a question regarding the practical use of the prediction results. You showed that the ontology-informed LSTM can predict data incompleteness, and you mentioned that this can ultimately improve healthcare outcomes. Can you elaborate on how these predictions can be used downstream in clinical workflows?
Okay, that is something that we have not investigated into, where, with that particular piece of the puzzle, we computationally came up with the method, and we kind of used publicly available data to see how the system would work. But we have not yet implemented it or tested it on with a particular clinic, because maybe we didn't pursue that path to find partners. But we have not yet fully figured out how where the clinical relevance is going to be. But we are hoping that there could be a clinical relevance, but we don't have the evidence to prove it, because we have not performed the experimentation based on the real-time clinical data. So that would be my honest answer.
Yeah, awesome. We also have a question, I think that sort of touches on the first question. This anonymous attendee has asked, thank you for the informative presentation. What would you recommend when working with incomplete data of a longitudinal data set? Do you recommend the imputation process? If so, what would be the recommended method?
I would highly recommend not to use imputation. However, as a researcher, sometimes we experiment and see what can be done for imputation, but that's just an experiment purpose only, because we are computer scientists, we are computer engineers, we like to play with things, right? We like to play with math, we like to play, but when it comes to real use, we try not to do it. For example, when I was a little kid, and I'm speaking in Australia, so cricket is very famous here. So we always played cricket with the tennis ball. We never use the kookaburra, the hard ball, leather ball to play cricket, because it could be very harmful, right? So so you needed all the pads and all the safety gears to play cricket with the real cork ball. So which we didn't have. So we played cricket with a tennis ball. So imputation, you got to be very careful. Not do it for just as a band-aid fix. Now, for experimental purposes, for predicting something, for doing experimentations, yes, maybe you can do that, but not in a real life scenario. That's what I would recommend.
Wonderful. Thank you for answering that. And we have one more question. Thank you, Dr. Raj. Is there any interest in adding a data quality layer on top of the completeness framework or process? Just because the data is present doesn't mean that it's accurate or useful. This may be another opportunity for significant healthcare outcome improvements.
This is an excellent statement. Actually, as I said in the beginning of the presentation, we got a ICAD work group on global data quality standards for electronic health records. That's exactly what we are trying to do. That's the end goal. And I'm glad you asked this question. Let me tell you why we are working with IEEE of all the places in the world. Instead of working with a healthcare organization, we are working with IEEE. IEEE sets the standards for data movement on the internet, right? For example, Wi-Fi is an IEEE standard. Your MAC address that is on any of the devices that gets connected to the internet, including this laptop, including my mobile device, my phone, and all that, has a MAC address. That MAC address is coming from IEEE. It's an IEEE standard, right? Sometimes you call it IMER address, there are different names given to it. So with working with IEEE, this is exactly what we are trying to achieve, is have a data quality layer that analyzes the quality of data. Having data, having healthcare data right now that may or may not have high quality, is not the most desirable thing moving forward. I think we definitely need a quality layer, and that's what we are working on. It's going to take a lot of time. It's going to take a lot of effort, but we started the process. We published our first white paper defining what an electronic health record is, defining what an electronic health record system is. And that white paper also had the definition of incompleteness for electronic health records, which is what I presented in the very first or second slide of mine. So ultimate goal of doing all this is coming up with what you just recommended. So fantastic question. Thank you very much.
I think we've answered all the questions in the Q&A, and I don't think anybody is putting their hands up and to ask a question verbally. So we might end things here for now, unless something else pops up in the Q&A. Oh, yes, there is something else in the Q&A, just in time. Could you please give some examples on how to do data quality checks in the layer on top of the completeness framework or process? I'm quite new to healthcare.
Oh, the answer to that question, it would be probably 72-hour lecture. So, all I can say is if you go to Google Scholar and you type my name on Google Scholar, you'll come up with a lot of publications that answers that question. But again, that question is not fully answered yet. This is an ongoing research. And that question is not fully answered yet. And one of the reasons I picked to come here is so that we can have folks from Australia join the bandwagon on that particular research topic, so that the Australian perspective is also taken into consideration. Luckily, going back to that ICAD work group, when we defined electronic health records and defined electronic health record systems, we had folks from Australia, from Australian universities, from Australian healthcare systems actively participating in that work group. So the Australian perspective was also taken into consideration. But my guess is there was nobody from Brisbane. Most of the folks were either from Sydney or maybe one or two from Adelaide. So, I would like to welcome you guys to be a part of that group. You can go online and just, fill up the smart sheet and be a part of the solution process. And so that would be the best answer I can give. Although this is a great question, and we can keep talking about it for a couple of days.
Yeah, awesome. Thank you, Raj. With that, I would like to bring the webinar to a close. Thank you so much to everybody who attended. I hope that this was very informative for you. Certainly, I found it very informative. And yes, please contact Dr. Varadraj Gurupur or Center for Data Science for more information on upcoming events this week. Goodbye.
Thank you.